Hello, and thank you for listening to another episode of Little Lies, Big Topics. This episode features a panel discussion on the future of retinopathy of prematurity screening and treatment approaches. Let's hear from Drs. Gil Binenbaum, Emily McCourt, and Jennifer Jung.
Welcome, everyone, to Little Eyes, Big Topics at APOS Podcast. I'm Dr. Jennifer Galvin, and I'm co-host with Dr. Christine Law for the ROP Updates, Pearls from Pediatric Ophthalmology Experts. We have with us today three outstanding guests, Dr. Gil Binenbaum, Dr. Emily McCourt, and Dr. Jennifer Jung. And Gil is Director of Ophthalmology and Chief at Children's Hospital of Philadelphia at CHOP, and Director of Research in Ophthalmology. Emily is Chief of Pediatric Ophthalmology at University of Colorado and the Children's Hospital of Colorado in Aurora. And Jennifer is the Director of the Retinopathy of Prematurity, or ROP service, at the Children's Hospital of Colorado in Aurora and at the University of Colorado. So welcome, Gil, Emily, and Jennifer.
So I just want to introduce myself as well. I'm Dr. Christine Law. I'm the co-host of today's episode. I'm a pediatric ophthalmologist in Kingston, Ontario, Canada, and I want to thank the three panelists who have come to really share their expertise with us in their big names in the field of ROP. And so I guess to start things off, I did my fellowship at CHOP, and so I do know Gil, or at least he put up with me for a year during fellowship. But just to get to know our panelists a little bit better, Gil, can you tell us just a little bit more about yourself and what drew you to ROP making a big part of your career?
So like you said, I'm at Children's Hospital in Philadelphia, and I didn't have to put up with you. It was wonderful working with you when you were a fellow. So I got introduced to ROP as a fellow myself at CHOP. We have a busy ROP service at CHOP, and we have a couple people who've contributed quite a bit to the field, in particular Graham Quinn, who I think is the only current person to have been involved in all three international classification editions. Basically, he's there from the beginning. He was even there when the term plus disease was first coined. He was on rounds with, I think, a fellow or a resident at the same time who came up with this idea in the early 80s. And so when I came, he was one of my main influences. And and so that's how I got introduced to ROP. And our fellowship has a lot of ROP experience for the fellows, both in terms of screening and treatment. And we'll probably get into it, but we have our sort of own way of examining the babies that's slightly different, I think, from some other places. And a lot of it does come from Graham and the other attendings who were my mentors in my fellowship. And I guess for the medical students out there, because I've heard that some medical students might be listening to this, just a pitch for how wonderful a field pediatric ophthalmology is, and especially ROP. And really, we're the main ones who are dealing with this disease, which is one of the leading causes of blindness in children worldwide. And so it's a very important thing to deal with. And the interventions that we do for ROP, I think, are amongst the most dramatic that are done in all of ophthalmology, because we can take a baby who's going to be blind for their whole life, and we stop that from happening, and then they can see for their whole life. And they haven't even left the hospital yet. And cataract surgery is wonderful, but doing ROP treatment really is even more wonderful. So just a little pitch for med students who are interested in ophthalmology to consider pediatric ophthalmology, and ROP is definitely one of the reasons to think about that.
Fantastic. Thanks so much, Gil. And yeah, for sure, ROP was a huge part of my fellowship, and I'm glad that I had the opportunity, because I still do it here in Kingston, Ontario, where our ROP population is a lot smaller. But I'd love to also hear from our other two panelists, both Emily and Jen. But Emily, if you don't mind starting first, just also letting us know a little bit more about yourself and what drew you to ROP.
Sure. So I'm Emily McCourt, and I'm the Chief of Pediatric Ophthalmology at Children's Colorado, which is part of the University of Colorado. And I was drawn to ROP pretty early in my career. And again, to tag on to what Gil said, it was from a medical student. So we had an inquisitive medical student who asked me just great questions. Why are you checking so many babies who maybe didn't need an exam? And so together we started looking at a lot of our data, both at Children's Colorado and our NICU here, and our NICU across the street at University of Colorado Hospital. And we tried to figure out this puzzle together. So I think that connects with what Gil said, because I think as a medical student, sometimes you can think that your role is not as significant as it is, but actually it's extremely significant and brings a lot of great questions to the table. I think also improving ROP care has just tremendous potential to impact premature babies, both during their NICU stay and for their entire life. And for those are my two main reasons I got into ROP and stayed interested in this topic.
Fantastic. Thank you so much. And Jen, would you mind also introducing yourself a little bit more and letting us know about why you've focused a lot of your career on ROP?
My name is Jennifer Jung, and I am also at Children's Hospital Colorado. And as I'm the director of the ROP services for 5 NICUs here in Colorado. The reason that I became more invested in ROP is a little more practical in that, to be honest, ROP became a bigger part of my career because I took on the role of director of ROP 6 years ago in 2018. And after taking on this role, I realized that ROP was very unique because unlike other eye problems that I treat on a daily basis, the clinical aspects of ROP is only half of what it means to run an ROP service. There's a lot of administrative work that's involved, implementing contracts, working with the NICU staff, improving efficiency of the workflow, maintaining a safe ROP tracking list. So these were all the other aspects that I did not really know about as a trainee. So as I became a director, I started enjoying tackling and solving these challenges as they came. So, and it's all for the babies, which is worth all the work.
Thank you so much. Yeah, that sounds fantastic. And I agree that all of that administrative and logistical aspects for these ROP babies, I agree that when I came back to my own institution as well, kind of revamping things based on what I had learned at CHOP. But was there somewhere where you grabbed from as well in terms of learning how to set up a kind of safer process for screening and making sure that all of the babies got the appropriately timed exams? And
yes, I did ask a lot of questions, not just within our institution, but I asked around to see how other people were running their services at other children's hospital across the country. The main theme was that nobody was happy and completely satisfied with the workflow and the system that they had, which made me see that we can really work as a team, not just within our institutions, but together to try to come up with a workflow and a system that is better than what we have individually.
And I'm wondering if that might actually be a good plug for the ROP update meeting as well, that I know often brings everybody together to learn from each other.
Sure, I'd love to talk about the ROP update meeting. It's going to be May 31st and June 1st, if that hasn't already passed when this airs. It's going to be in Denver at Children's Hospital Colorado, and I'm really excited. We have over 100 ophthalmologists from all over the country, and actually some from out of the country that will be attending. And it's going to be a really great place for people to share their best practices, to talk about their hardest cases, and to learn from each other. I also think that this kind of conference is really demonstrative of how collaborative the pediatric ophthalmology community can be, with the common goal of improving vision for premature babies. The ROP update meeting is held every other year and in different locations. So this year in 2024, it will be in Denver. But stay tuned on the ROP update website for our next meeting for 2026.
No, that's great. Thank you for sharing that with us, Gil. How would you say your fellowship is at CHOP in terms of the pediatric ophthalmology experience in terms of caring for and screening and treating babies with ROP?
I think that our fellows get a great experience that's it's pretty in depth over the course of the year. So we actually screen at quite a few hospitals. I think we're like at 11 or 12 now. But the two main hospitals the fellows are involved in are CHOP, or Children's Hospital itself, and the adult, hospital at the University of Pennsylvania next door. And so those are usually being done on the same day. It's a whole day ordeal. The list can sometimes get up to 40 or more between the two hospitals, so it could be many babies. And so when they first start, basically we look at every baby, and they look at kind of every other baby, and we double check what they did. But then as the year goes on, we try to increase their autonomy, and then we also do quite a bit of treatment. So perhaps we'll get into it along the way, but we do both injections and lasers. And we tend to laser a lot of our kids who had injections. So our fellows get quite a bit of experience with both types of treatment and quite an in-depth discussion about when to do which, and how to manage post-injection babies sort of longer term. At least they learn our way of doing it, but we kind of do discuss the variety of approaches, because we know this is kind of a controversial area about exactly what to do. And then finally, we do have a pediatric retina specialist, so it's not too common that things have to progress on to lens-sparing vitrectomy or a buccal procedure, but they get to see that as well.
That sounds fantastic in terms of how comprehensive that is, but then also not only the breadth of hospitals, but like you mentioned, in terms of the sheer volume. And one thing that, since you were talking about just the specifics, what is the preferred examination and screening approach in terms of speculum, no speculum? They're using a direct ophthalmoscope with a lens and imaging.
I guess another strength of our fellowship is we actually have quite a few ROP providers. So the fellows get to work with all of them, and we all have slightly different variations on how things go. There are a couple people who use speculums on pretty much almost everybody. And then there's people like me who use speculums on almost nobody. I pretty much use my fingers. I always try with my fingers first, trying to get right on the lid margin. Not pulling on the skin, but actually pushing apart the lid margins. That's an important distinction. And I think I get a sense pretty quickly of whether or not I'm going to get a good enough view. And if I'm not, then I'll switch to a speculum, pretty quickly. And finally, I hardly ever really use a depressor. If I do, we use Calgi swabs. I don't know if other people use those or not, which is like, a little metal Q-tip with a really fine little cotton thing at the end. So we tend to use those as our depressors. They work really nicely. And if I ever do, it's really just to sort of rotate the eye as opposed to depress. I depress aggressively during treatment, during doing laser, but not so much for exams. At least that's the kind of technique that I personally do. And again, there are people at CHOP who do use speculums more routinely, and we definitely emphasize that the bottom line is that you need to see what you feel you need to see to make the call on whether you're going to treat or see the baby in a week or 2 weeks or 6 months. That's the basic, simple decision to make. And if you're not getting the information you need to make that decision, then you have to kind of escalate to the next level of, aggressiveness with the exam, so to speak.
No, those are great points. So, Jen, what I was also going to ask you a similar type of question, but ask you about your preferred examination and screening approach, about the speculum, no speculum, the imaging or direct ophthalmos with lens at the Children's Hospital of Colorado.
In our institution, we also have 8 pediatric ophthalmologists who do the rotations for ROP. So we do have a variety of pediatric ophthalmologists who've had trainings in different institutions. So there are some variations as well. Personally, I do use indirect ophthalmoscopy with a speculum most of the time. And the depressor, if I use it, is really to rotate the eye. But by using the speculum and the depressor to check, the exam would usually take 30 seconds or less than that. So we try to, our goal again is to try to see well and try to do that as quickly as possible. Um, for our retinal cameras and photos, we do routinely take photos when ROP is worsening, for documentation, and also during transition of care. I think it is very important, if there are many pediatric ophthalmologists who are screening, to have a good transition of care, that sometimes the descriptions on the exams may be limited. And so we try to take photos so that the next ophthalmologist knows exactly how the ROP appeared, so we can follow the trend and just how the ROP has been worsening or improving over time.
And that is great that you have such a robust team, Jen. Emily, is there anything you'd like to add as well? I know you're part of the team.
Yeah, so Jen and I have very similar practices. For me, an efficient exam is the best exam. I use an eyelid speculum, and I use a depressor, like Jen said, mostly to rotate the eye. I love the photos. I take a lot of photos, and I think part of it is the transition of care, and part of it is teaching and education. So if the nurses, if the parents, if the other family members understand what we're seeing, what we're concerned about, I find in general people become much more engaged in our process. I completely understand that everybody's exam technique is what's most efficient for them. So for me, that's what I found, but it's just about what you need to do to see that retina.
I think that one consistent theme between the three of us is that we're trying to be as efficient as possible to minimize the stress on the baby. And an issue, maybe you'll both all agree, that comes up not infrequently is a nurse or someone else on the team being concerned about the stress on the baby, and that the baby had a procedure yesterday or is having a rough day today and they want to postpone the exam. And this was getting to be a bit of a problem. And so we kind of created a policy that there would be no unilateral cancellation of exams. There had to be if they wanted to cancel an exam, they have to now have a discussion from their attending to our attending, because they know about the health of the baby, but they don't know about the risk to the eyes, and somewhat vice versa. We know about the risk to the eyes, but not as much about the baby. And when you do a really efficient exam, even if you can only get a look at the back of the eye to see if there's plus or not, then you at least know usually if you're going to have to treat, and then you can move on after just a few seconds of getting a quick look. So at least in my experience, I haven't really found even a very sick baby who couldn't tolerate a very quick look like that. So just that's a helpful thing to maybe discuss ahead of time with your NICU director.
That's an excellent point. And I just actually have a question more from a practical standpoint from my own learning, following up with that in terms of nurses, because sometimes I find some nurses are more comfortable in terms of little babies that have the CPAP machine where the strap's kind of taped up all over their forehead, kind of releasing it and turning it around so that I can get a better view at the eyes. Do you typically, what's your approach to that? Some nurses just don't seem to know how to do it, or I'm not sure, do you just ask the nurse whether or not they can do it, or do you kind of have kind of a standard approach to, or tips in terms of how I can get a better view when the CPAP isn't movable at all?
So at Colorado, we're lucky that we have a NICU nurse who does rounds with us. So maybe we're spoiled, but I would highly recommend that you insist on that, because the nurse who's doing ROP rounds with you really understands the importance of doing something like moving the CPAP if he or she can, because it really makes the exam much, much faster and much easier on the baby than if you're trying to look around the CPAP. I think, to Gil's point earlier, if you really can't take the CPAP off for some reason, really getting a posterior pole look, and if there's, you can sometimes see at least nasally a little bit to know if you need to come back sooner, but that can help guide you and at least put off the exam for another week if they're really, really tenuous. but I would highly recommend the nurses teaching each other.
I guess maybe we'll just switch gears a little bit, as hopefully most of us know, but it might be new to the viewers, is that there was a fairly recent revision of the International Classification of ROP that came out. And I guess for the panelists here, just in terms of what you guys think were the most important new modifications or changes in how that affected your management of the patients in your NICUs. Jen, if you had any comments maybe regarding that.
To me, the revisions were more specifically defining what we've been seeing clinically. And so it gave us standardized words and vocabulary and phrases to describe the findings in more detail. So these detailed descriptions have been very helpful since not all stage 2 zone 2 ROP are the same, and severity can be varying even within the same stage. And so a more detailed exam note, again, is better to follow the trend and the direction of ROP and also during transition of care. So I think that was the biggest helpful part of the revision for me personally, because I am now able to use a more standardized vocabulary to describe what I am seeing and what everybody would be on the same page and understanding the exam better.
I mean, I agree that it was kind of making standard nomenclature that, exactly like Jen said, that things that we knew already. I mean, for example, notch is a concept that's been around before any of us started doing ROP. So, it just has officially been incorporated. I agree with Jen that, many of the things that have been formalized now into ICROP3 are things that were known already. But the changes to plus disease, however, are a little new. So traditionally, I was always taught to judge plus disease right around the disc. And that came in the peripapillary region, and not to look at the rest of zone 1. That's sort of an artifact of the original classification. The standard reference photo by which to judge plus disease is sort of a narrow angle right around the disc photo. And it turns out that photo was chosen because that was what was available, not because that's what they necessarily intended. And so I think some of the variation or variability we've seen amongst clinicians and even amongst experts in plus diagnosis perhaps has come from people using different geographic areas to judge plus, which is such an important thing to do because clearly that's one of the main elements in our treatment decisions. But now with ICROP3, it's more clear. So we're now supposed to use all of zone 1 to judge plus, and we're no longer supposed to distinguish between whether it's arteries or veins that are tortuous or dilated, as what it originally was in the first 2 iterations of ICROP. So there's been some pretty specific modifications to the plus disease diagnosis, which are a little different, and I think a little more flexible for the clinician, and I think capture better sort of the gestalt of what's going on in terms of plus-like change. The final key thing was that there was a formal recognition that plus is actually occurring along a spectrum of vascular change from nothing to really severe plus. And I think as we move forward in ROP research and then clinical practice, I think we're going to have more detailed treatment decisions being made in terms of attaching that to certain levels of plus-like change, not just this one sort of threshold, yes or no for plus.
I remember seeing a lot of this, even with you during my fellowship, though it's great to have a terminology and being able to describe things more formally.
And another question I had for our panelists is that the CROP and GROP study showed higher sensitivity in the stricter criteria of disease detection up to 100%. And what do each of you think that future screening ROP modifications will look like or will involve? Emily?
I'm going to answer your question with another question, which is our pediatric ophthalmology community and our neonatology community really ready to make changes in our screening parameters at all? So a lot of us, so Gil and Jen and I have all worked on different models to see which one would be the best. And we can argue, is it the GROP? Is it the CoROP? Is it something else? But I think the barriers are finding a simple model that doesn't miss any babies and that would be widely accepted. I'm not convinced yet that our community is ready to make these changes despite some decent evidence that we could. I don't know, Gil, what do you think?
I think you're absolutely right. But I also think that our community is absolutely right for resisting changes, for efficiency's sake that could actually hurt the sensitivity of our criteria. I think that we've in some ways been focused in the wrong direction in all of this sort of research, in the sense that we keep focusing on trying to make our criteria more efficient or more specific, examine fewer babies, because so many babies don't even develop ROP, let alone need treatment. And I think that the real question is, how do we make sure that we're not missing any babies? I think we can all agree on that. And I think that one thing that has come out of the research that's been done is that it is possible to improve the sensitivity of our screening criteria over the current criteria. So, we're currently examining, conceptually two groups of babies, higher risk babies who are lower birth weight gestational age. And for those babies, all you really need is birth weight and gestational age to figure out who they are. And then the outliers, who are the higher birth weight and gestational age babies who still need to be treated. And so what this research essentially has been doing is trying to identify those outliers better, so that we can then lower the birth weight and gestational ages of the kids we need to see, so that we can have more efficiency or examine fewer babies. But I think we should actually separate that into two different questions. And if we do, I think the answer actually becomes much clearer. So for the lower birth weight gestational age babies, it's exactly what Emily is saying. No one's really willing to take a risk on that to improve efficiency. But for the outliers, it is clearly possible to identify them better than the current way. And the current way is to have a third criterion, which is, if the neonatologist thinks that this baby was sick enough, we should look, which is completely nonspecific and subjective. And I think the real question is, let's just put aside the efficiency altogether and focus on how can we make the criterion 100% sensitive, or as close to that as possible. And the answer is to take some growth criterion and add them to the ones we're already using and examine more babies, because we're not at the point where it's not missing someone. We know that they're not 100% sensitive. That's why we have that third criterion. So I would argue we should be less efficient and examine more babies so we can get to 100% sensitivity. And I don't know how everyone feel about that, but I can't see anybody disagreeing with the basic idea of capturing more babies who need to be treated.
I think the key for all of this is making sure that it works in the cohort that you are working at, because there's such a heterogeneous population across the United States, but also just in the world, that a model that works in one population may not necessarily work for the other. I think that's another difficulty and challenge in widely spreading and accepting a new algorithm as the screening criteria. So validating in your cohort before considering making any changes. There may be multiple validations needed over years to make sure that even the population within your cohort is not changing, like the risk factors and just in general the characteristics of that population. So it is a complex question, but something that is worthwhile to continue to make efforts in studying and continue to work on. So
I also think you need about 10 more fellows per year to train to screen many, many more babies. We have to think about who's at risk in your cohort. But I also think we have a workforce issue, right? So how many pediatric ophthalmologists is it going to take? Should we check every baby? Is that, what's the limit? And I think that speaks to the fact that as obviously I know pediatric ophthalmology is the best specialty to go into, but it's another reason that our listeners should consider pediatric ophthalmology if you weren't already, is because there's definitely a need for people to understand ROP and understand eye exams in the newborn and in the premature infant.
There have been many recent reports of automated algorithms and the role of deep learning and AI, and in terms of making an accurate ROP diagnosis. And I wondered what the panelists thought about the current practical implications for pediatric ophthalmologists who aren't necessarily experts, such as all of yourself. I'll start with you, Jen.
This is something that is very exciting and that we are actively part of in validating these algorithms, with hopes that in the future we can implement some of these into our practices. But my vision that I have for the future is that because the first exam for ROP is rarely a treatment requiring ROP, my vision is that we can take photos to replace in-person exams and use that photo to run the AI algorithms to anticipate the risk for this particular patient and then adjust the number of exams accordingly for that patient. So that is something that I think is reasonably implementable in the near future. And I'm excited to try to see what the results would be within our cohort in the next few years.
I think one limitation will be, the equipment and making sure that places have cameras. A lot of places that are losing that workforce to do screening are community hospitals or lower level NICUs or that may not be able to afford the camera. Figuring out a way to get the pictures done or doing this with some sort of connector to a smartphone type to get images is important, I think. The last comment I just have is so these are not foolproof systems. And my general opinion is that as much of this that can remain under control by a human as possible is the best. But when you run up against resource limitations, you may not have a choice. And I think that's where AI really can help.
I think the only thing that I would add to that is one of my dreams for AI, and I'm hoping this is reasonable, is that it can change me from saying like, oh, that ROP looks angry, or that ROP looks scary, that ROP looks, insert whatever adjective I have for the day, and turn it into something quantitative, whether it's plus disease or this is a risk score of whatever. There's something that we know we see that's like a feeling or a gestalt. There's something that we see as ROP examiners that that we feel, and I would love to see AI quantify that for us, so we can again put a number or put a value or put something that's not just a descriptive word onto that. So that's my dream for AI, and I'm hopeful it'll do that, whether that's a risk score for plus disease or just a risk score in general. But that's my dream.
I guess I'm going to switch gears a little bit. So when your patients age out of the pediatric clinic, do you recommend they follow up with a retina specialist yearly or a comprehensive ophthalmologist yearly? Or, and I guess that would vary depending on if and what type of treatment they've received, or, but yeah, just some general wisdom.
Yeah, no, I think that's a great question. So a lot of our patients who have ROP that's resolved, we send them out, do regular screenings. And once they've gotten to a certain age where they can do the eye chart and we feel confident with both their retinal exam and their visual function, they get screened at their pediatrician like any other child. Patients who have avascular retina, who had treated ROP, I think that's a completely different beast. Anybody who I'm doing a depressed exam on or getting really far peripheral photos or an FA, they get sent to retina. And I think there's a big chunk in between that I'm like, you should see an ophthalmologist every year forever because I'm worried about your risk. But I don't have a standard follow-up regimen. I think that's that's another place we could really make gains as pediatric ophthalmologists and using more data to understand where we really should be sending these patients. Because I think as the patients that have gotten these new treatments get older, we're not really sure where they should end up and how high their risk is. So I don't know if Jen or Gil have other thoughts on that or have a more standardized approach, but that's what I'm doing right now.
I generally agree with what you're saying. And in talking to pediatric retinal specialists who are looking out in the peripheries of kids who used to have stage 3 that's now regressed, let alone disease that's been treated, that the retina out there is not normal. There's lattice-like change, there's holes and tears that develop, and with quite a degree of frequency. Certainly enough that I think it mandates, annual exams with a retina specialist. If you have, as Emily said, a persistent avascular retina, my approach to that is basically if you had stage 3, you need eye exams every year for the rest of your life. And with me, that's, until you're a teenager. And then if you're going to transition, I would say, off to a retina specialist. And the kids who had mild ROP, I don't feel the same about. And just like Emily, at some point, if they don't have significant refractive error, strabismus, et cetera, then we just kind of discharge them. So we're following basically the same thing. But I do think that there is quite a bit of risk for retinal complications as they get into young adulthood, even not much later. And a whole other realm of research, I think, that's coming up is what to do with persistent avascular retina, which before the advent of anti-VEGF injections was a little bit off the people's radar, I think. I'm not so convinced they need to be treated at an early age, but I do think that they probably do need to be treated prophylactically at some point, whether as teenagers or maybe even earlier. But that's a whole bunch of research, I think, that's coming down the pike.
Do you guys have any additional practical tips in terms of these babies that are having this persistent avascular retina and they're getting into the more challenging ages of examining? And what tips and tricks do you guys use to get a good clinical exam? Gil?
I use a retinal laser. So basically, I think there's some evidence that you should wait until around 60, 65 weeks PMA to give it a chance to fully vascularize. We tend to do it around 50 weeks post-menstrual age. If they haven't vascularized by that point, we laser them. If there's any kind of reactivation post-anti-VEGF before that, we laser them. If they're going home and we're not sure that they're going to come back, we laser them. If they're going to have surgery for some other reason and they still haven't vascularized, we laser them. So we do a lot of lasering them as an approach because it really, I think, is very impractical to do repeated EUAs, to try to do repeated even fluoresceins, if some people do that. And it's just to examine if, once they're like 55 weeks post-menstrual age in the clinic, you just can't get a look. I mean, you can't look all the way around to look for reactivation. And my only last comment is I think that this is another area where we need more data because there's reports of reactivation 3 years later. And so that's a long delay. And then there's reports of people who don't, laser any of these kids and just follow them and they're 5, 6, 7 years old and still haven't had a problem. Although they're not all necessarily getting EUAs to really know that there's no problem out there. So I think there really is some data to support either approach. And I don't think there's a clear answer. So really anybody's approach is from not treating any of them to like lasering all of them. I really think you can justify any of those approaches. And so we need some study to tell us what to do.
Yeah, thank you, Gil. And Emily and Jen, what are your approaches for each of your practices? Do you have a tendency to also kind of do more EUAs, laser?
We do have a similar rule that after postmenstrual age of 50 weeks, trying to find an opportunistic EUA and a time to laser prior to discharge. So that's the general rule that we have amongst our group. However, even with this, we have had babies who were discharged before we were able to do a laser, or babies who somehow didn't follow up and later came back without having had laser, and we lost the opportunity to do that. So in our practice, I think we're seeing both. We have patients who we did the laser as we planned, and we have a set of patients who have avascular retina and are doing fine. So for those patients, we're following them on an individual basis if they had higher risk ROP, and if their ultra wide field photos show abnormalities, we may do an FA on those patients. So like Gil said, we don't have one consistent answer, but it's important that we're going to need to follow these patients closely. One tip that I do have on these older babies, where if we're trying to determine if they have reactivation, but they don't have a EUA coming up, instead of using a depressor, I often use a proparacaine soaked cotton tip, because it gives me a little more friction, and it's a dollar tip to be able to see the periphery a little better in a faster manner. So that's one tip that I try to use if I have to examine big older babies.
Well, that's a great tip. I've never tried that before, but I'll definitely try that in the near future. Thank you. Emily, did you have anything you wanted to add?
Yeah, I think, the question was like, what's going to help me with a proper exam? And in my head, it was anesthesia, but I think other things that help are, well, always listening to the mom, because the mom sort of knows the best way to keep the baby comfortable. Is the baby going to breath hold? Do they need a pacifier? What's going to work? Usually those babies are vascularized nasally, hopefully. If not, they definitely need laser. But if not, I just go extra dilating drops all the way temporal and get the exam done as fast as possible. And like Jen said, an opportunistic EUA, we call it. So for better or worse, a lot of these kids need anesthesia for something else. So it's just tagging yourself on. And I think in my mind, I really differentiate the post anti-VEGF babies from the persistent avascular retina babies that are just never finished vascularizing. I think the post VEGF babies definitely need laser. Like, I'm not watching them every couple weeks until they're 5. That's just not feasible. And I don't think you're getting good enough exams. But I think the ones that just never fully vascularized, maybe they had regressed stage 2 or 3, and they just have avascular retina. I feel comfortable waiting until I have an opportunity to laser them. So maybe they'll need ear tubes. Maybe they need, a hernia repair. So I think there are 2 different groups of patients.
This is excellent. And one thing, after talking about a lot of these different topics with all of you as experts, what advice would you give to medical students and ophthalmology residents or other trainees interested in becoming involved in ROP clinical research, and to volunteer clinically or shadow to learn more about ROP?
Yeah, ROP is always going to be with us. It's never going to leave us. So it's here to stay, and we're going to probably see more with the advances in neonatal care as it improves further. So I would encourage students and trainees to not let ROP intimidate them, but really kind of accepted with a welcoming heart that it is here to stay with us. And so we're going to have to get along, and we're going to together as a team do a even better job in trying to combat this. And then it's a skill that can be learned, and the impact is truly meaningful. So my advice for the trainees and students would be come and see the exams and ask questions, see the photos. Fresh eyes from medical students and trainees help expand our creativity and kind of gives us new perspective in finding out areas where we can even improve further, so that we don't settle for complacency and stay where we are. So my advice would be come and just immerse yourself and ask questions. No questions would be too little or small, and that may actually help us move our team on to combat this even better.
I completely agree. And I would just add one thing, which is, the current big third epidemic of blindness from ROP is all occurring overseas. And so I know many medical students, trainees, as many attendings, have an interest in international or global ophthalmology. And a lot of the real action here is in Africa and in other parts of the world where there is a true epidemic of blindness. And a lot of it's coming not because we're arguing about screening criteria slightly higher or lower. There are no screening criteria. There is no infrastructure or resources to do screening, let alone do treatment. And so there's a lot of, I guess you can call it sort of international mission work for ROP that I'm sure students could get involved with, and would definitely help spark a passion for helping babies not go blind from this disease.
Thank you so much to this outstanding panel, Gil, Emily, and Jen. And on behalf of the Digital Education Committee, Christine and myself, really thank you for sharing your time with us. And I know all of our listeners are going to learn a great deal about not only pearls about ROP, but the future about this field. Thank you for listening, and most importantly, thank you for joining us.